Yeah, it's recording. Okay, good. Okay, we do see 94 and 24 people, so around more than 100. We'll give some few minutes.
For all the everyone to mute yourself, please, except Gani.
I'm sorry. Yeah. No, I can't see the screen over there. Like I just share the screen. Okay, shall I start? Maybe we need to give one more minute. People are joining. Okay, we'll start. Good morning, everyone, or good afternoon, or good evening to whoever, wherever you are in the globe, and welcome to the Focus Neo 8th Symposium on Advanced Neonatal Care. And this symposium focuses on the NIRS 6th vital sign. And it is a continuing series of symposium from Focus Neo. And let me introduce myself. I'm Dr. Muzaffar Ghani Abdul Wahab. I'm the co-chair and founder of the Focus Neo and Neopeds Academy. I'm the associate professor and neonatologist at Division of Neonatology at McMaster in Hamilton, Canada. And it is my pleasure to introduce Dr. Yasser El Said, and who is the co-chair and founder of Focus Neo and Neopeds Academy along with me, and he is an associate professor and neonatologist at University of Manitoba, Winnipeg. And welcome, Yasser. And it is my pleasure to thank our sponsor for this symposium, Medtronic, through an unrestricted educational grant to support all the symposiums done by the Focus Neo. I would like to appreciate their generous donation through the educational grant. Thank you, Medtronic team. And our executive committee, patrons, advisors, international collaborators, and administrative and technical teams of Focus Neo as well as the Neopeds Academy. Thank you for your continuous support. And as I mentioned, this is one of the largest virtual event of the year. And we have currently more than 750 participants attending this event, and they are from 81 countries across the globe, and growing number every year. And please note, you must log in for this session with the PC or Mac using your browsers, Chrome or Firefox, and stay connected in the session one. So this is a session, actually there is some technical glitch on the session one. So this is a welcome note session, and once you are joined, you please stay in the same session. If accidentally disconnected, please sign in with the same steps and join this welcome note session. Please type your questions in the Q&A section only and not in the chat. And please refrain from asking for the microphone to speak, because we have larger audience, we cannot offer the microphone to everyone. Our moderators will be speaking on behalf of you with your questions, so don't worry about your questions will be asked. For any other technical assistance, please click the chat window below, like on the left lower corner of the event page, and our team, support team will be assisting you. Or you can even send the email to support@focusneo.org. Please watch for the follow-up email for the feedback link you will get, and that will lead to issuing the CME certificate. And please save this portal. We are having all the resources will be given here. Okay, so I would like to apologize for my slides, which has jumbled today. Yeah, okay. Maybe I'll just go with the same sequence. So just a small announcement about our upcoming conference, which is in May 2nd in Toronto, Canada. Those who did not register yet, please avail this great opportunity. And it is going to be in Toronto and Beanfield Center, and only limited seats left. Please rush to get your last seats. And in a couple of weeks, we are going to start on May 2nd in Toronto. And it includes all the topics in ventilation strategies in both the neonatal and pediatric, with the advanced respiratory care topics. And the agenda is there. You can look at the agenda. The speakers, faculty speakers, are world-renowned speakers from all over the world. And we have 5 workshops running in this whole day. That is a very important state-of-the-art workshop, and please do not miss that. And also, just taking this opportunity to introduce our new courses has been added to the NeoPeds Academy, and you can browse the courses in the featured courses. Now we have the PPHN complete courses there online, along with the focus modules, and cranial ultrasound is new, and newer lung ultrasound courses, as well as hemodynamic courses already online. Please make use of the courses in neopeds.academy. And just to those who are not aware of the diploma training program in focus and hemodynamics, we run for institutions, and still individual registrations are not yet open. So if you are a group of 10 in your institution, so you can apply for this institutional training program. The information is there in neopeds.academy. Please go through that, and we are accepting more institutions from now on. And with that, I welcome to today's speakers, Dr. Gabriel Altit and Dr. Samer Yusfi and Dr. Yasser El Said, for making this symposium one of the biggest and most wanted event. So to share their expertise in NIRS. And I would like to thank their commitment and their time for this symposium. Thank you. Well, I would like to introduce, shortly, I would like to mention about our panelists, Dr. Jaher and Dr. Mansoor Faruqi, for kindly accepting to be the panelist for these discussions. And I would like to introduce the moderators for this session, Dr. Adil Muhammad and Dr. Nadia Benfadel. Those who are kindly consented to conduct these sessions, they are core members of Focus Neo and NeoPeds Academy, conducted several events online. And I welcome Dr. Adil Muhammad and Nadia for this event. I would like to introduce Dr. Adil. He is a neonatologist and associate professor based at Mount Sinai Hospital in Toronto, Canada. He serves as a director of a point-of-care ultrasound program, and he is the national lead for POCUS lung ultrasound implementation program. Dr. Muhammad has been awarded the Canadian Neonatal Network grant for the lung ultrasound educational portal, which spans across all Canadian institutions. Additionally, he plays a crucial role as the faculty lead for the Neopits Academy lung ultrasound courses, which is already I have showed you, and serves as a faculty mentor for physicians enrolled in the program. And Dr. Nadia Ben-Fadel is an associate professor at the University of Ottawa, and she's a neonatologist at the CHIO and Ottawa Hospital. She is currently the program director of the Neonatal Hemodynamics and Targeted Neonatal Echocardiography AFC Diploma program in Ottawa. Dr. Ben-Fadel has a keen interest in neonatal hemodynamics. Her main research focus is on the use of PNECO and POCUS in NICU. Welcome, Dr. Adil and Nadia, and the platform is yours. Please moderate the sessions.
Thank you so much, Gani, for the nice introduction, and thank you for including us in this wonderful symposium. As we'll go with the sequence of the presentation, we'll start with Dr. Samir Yousefi, who will be presenting first for us. Dr. Samir is neonatologist and clinical instructor, pediatric department, Seri Memorial Hospital, Vancouver, BC, Canada. So please join me to welcome Dr. Samir for his presentation. Dr. Samir.
Thank you, Dr. Muhammad, for the introduction. And thank you for POCUS and for Dr. Abdul Wahab and Dr. Al Sayed for giving me this opportunity to be part of this symposium. Can you see my slide?
Yes, we can.
Yes.
Yeah.
Are you able to see my slide?
We can start. Yeah.
Yeah, we can see the seat.
Yes, we can. We are able.
Can you hear me?
Yeah, I hear you. Can you hear me?
Yes, yes.
Okay.
Yeah.
So again, thank you so much for allowing me to be part of these presentations. And my presentation will be short for about 10 minutes. I have no conflict of interest to declare, and I don't have any financial relationship with profit or non-profit organization. I'm hoping by end of this presentation, we'll be able to distinguish the difference between arterial O2 saturation and near-infrared spectroscopy, explain the concept of oxygen content and oxygen delivery, and describe the clinical variables which will have impact on oxygen content and delivery, and appropriately integrate the NIRS reading at the 6th vital sign with other clinical variables. So let's start. The near-infrared spectroscopy, it can be applied to multiple organs, but I have chosen mostly to talk about the brain because mostly we'll be using the brain in the neonatal intensive care unit. So to start with, what's the difference between oxygen saturation, arterial oxygen saturation, and near-infrared spectroscopy? So in the arterial, the usual vitals we have in the unit is the O2 saturation, which we check how much saturated in the blood in the arterial circulation. Let's assume we have a patient with saturation 100%, and that's what's going to the brain. Once it's past the brain on the venous circulation, if you check the saturation, it's not going to stay 100%. What's been given to the brain is not going to be all consumed. So if the brain is seeing 100% saturated RBC, in the venous circulation, we're going to see probably about 75 or 70% saturated red blood cells. What that means? The brain took about 25% of what's been given, and that's what we call oxygen extraction. So normally, in a healthy situation, organs extract portion of what's been given. Normal extraction usually for organs between 20 to 30, 35%, depending on the activity of this organ. So what's left over in the venous circulation, that's what saying that's the 75%. That's what near-infrared spectroscopy will measure. So to start with, the arterial O2 saturation will measure what's being provided to the organ, and the near-infrared spectroscopy will measure what's left over. When you use the two values, you will have an idea about how much the organ is extracting oxygen. Is it taking too much oxygen, or is it taking little oxygen? And you're going to use this value to guide your care. Again, the near-infrared spectroscopy, you can measure this leftover oxygen in the brain, in the liver, in the kidneys, in the abdomen. So to make simple things even more simple, let's assume we have two patients, patient number 1 and patient number 2. Let's assume patient number 1 hemoglobin is 70, and patient number 2 the hemoglobin is 140, so double the hemoglobin in patient number 2. Let's assume both of them are satting 100%. So which one of the two patients circulation contain higher amount of oxygen? Definitely patient number 2. Patient number 2 has much more higher hemoglobin, so the hemoglobin content in patient number 2 is almost double. So that's the second concept I want to introduce. So the first concept was oxygen extraction, and now we're going to talk about oxygen content. So being satting 100% will not reflect the oxygen content for a patient. You can sat 100%, but yet still your oxygen content in the circulation is very little. There are patients who might be dying with the saturation of 100%. So as much as the O2 saturation is important, it's not enough by itself to reflect what the organs are seeing in terms of oxygen. I always like to have this formula when I think about oxygen content and oxygen delivery. The oxygen content, it's 1.34 multiplied by hemoglobin multiplied by O2 saturation plus 0.003 multiplied by PO2. To make things simple, the last portion of the formula, the 0.003 multiplied by PO2, is very simple. So you can tell the PO2 will not much contribute beyond certain value much to oxygen content. What really contributing more to oxygen content is the hemoglobin and O2 saturation. So again, the main message from this slide is having an O2 saturation of 100% is not enough to reflect the hemodynamic condition and the oxygen content for a patient. So back again to the same formula, oxygen content. As I mentioned, if I keep increasing the FiO2, I can increase your SAT. But once I get to a point or your RBC saturated at 100%, there is no more room. I maximized your saturation. And the best, based on this formula, the best thing to do next after optimizing saturation is to optimize the hemoglobin value. That's what's gonna improve oxygen content. If, again, based on this formula, if you keep increasing the FiO2 beyond this high saturation, all what you're doing, you're increasing the PaO2, which will contribute very little to oxygen content. So And that's just this higher PO2, all what's doing, it's increasing the free radical and causing more harm. So in my opinion, no patient, based on this formula, no patient receiving oxygen supplement should be satting 100%, because based on this oxygen dosation curve, once you're sat 100%, once you're sat in high 90s, you lost the track, you don't know where your PO2. And ideally, to accept sats less than 100%, it will be your decision how low you're going to accept, but no patient should be satting 100% while receiving oxygen. And to optimize oxygen content, let's give optimized hemoglobin and fix the anemia. That's best way. Now, well, I did mention that oxygen content matter. Oxygen content, that's what's gonna be carried to the organs. It's not just about the oxygen. If your oxygen content is high, but it's not being delivered to the organs, that's gonna be a problem. So that takes us to the third concept, oxygen delivery. Oxygen delivery, it's the oxygen content multiplied by cardiac output, which heart rate and stroke volume. So to summarize, the best way to make sure oxygen content are optimized in any patient being taken care of in the ICU setting, make sure hemoglobin is appropriate, make sure stats are appropriate. There's no point from giving oxygen beyond, definitely beyond 100%, beyond high 90s, and optimize, make sure the heart rate and the stroke volume and the myocardial function is working well. Now, so we are familiar with the three concepts. We have oxygen delivery, organ extracting portion of this delivered oxygen, and the leftover after in the venous circulation, which is the mixed venous stat, which is the NIRS reading. Now, as I mentioned in the first slide, normal situation, what you provide the organ is usually this organ will utilize 20 to 30%. If the brain see 100% autosaturated arterial blood, what you're going to see in the venous circulation 70-75%. If you're giving the brain is seeing 90%, you may see in the venous circulation 60-65% left over. If you provide the brain too much oxygen, then the brain does not need to take all these 30%. The brain may take only 20% because there's so much oxygen being delivered to this brain. If the brain is not seeing much oxygen, on the other hand, if you're providing little oxygen, then the brain is going to take all the oxygen provided to it, or more than 40-50%. So what you're gonna, how NIRS is going to be utilized in a clinical setting, basically you're going to look at the NIRS, look at the provided oxygen, and look how much is the oxygen the organ is utilizing. Is it utilizing too much oxygen, or is it utilizing too little oxygen? This is a table, and I'm sure Dr. El-Sayed will be explaining it in much more details. But on the left side, if the brain is using very little oxygen, that means the leftover is going to be higher. The NIRS value is going to be higher. So that's how you're going to, one of the application of NIRS, if the NIRS is high, am I giving too much oxygen? Is the brain tissue dying? Is the brain over-sedated? Is the CO2 is too high, giving too much perfusion to the brain? If there is a hypoglycemia, those are clinical examples where oxygen consumption will go low and NIRS value will go up. On the other hand, on the right side, let's assume brain is using too much oxygen. Is it because I'm not giving enough oxygen? I need to improve my blood pressure? Is it because my CO2 is too low and it's time to check blood gas? Is it the lungs is overinflated, compromising blood drainage from the brain? Is there a seizure going on, subclinical seizure, and we're not seeing it? Should I check a blood gas? Should I check AEG? Should I adjust my ventilator setting? So that's how NIRS gonna be in a clinical setting used based on how much being provided to the organ, how much being left over, and how much the organ is using. Always we're gonna use a baseline, and we're gonna, from this baseline, we're gonna measure, are we going up or down? This is the last slide, and the reason I would like to have it, at the place where I'm working, we recently introduced near-infrared spectroscopy. It's about 2 months old. And as we are implementing it, one night I was working and I was explaining it to the nurses that shift. And later, after 1 hour, I stopped by the room and I asked, "Hi, Katie, how is the brain is doing?" And Katie's answer was, "Brain is happy. Brain is using just the right amount of oxygen, not too much and not too little." She made my day. And the reason I like to have this slide on, just to highlight the importance of nursing education, RT education. And in my opinion, it's more important than even physicians' education. So as a place where we just started rolling out near-infrared spectroscopy in an ICU, making sure the staff who are working at the bedside and using the device, their questions being addressed, and they've been approached because they're crucial in successful implementation for NIRS. And hopefully I achieved my learning objectives, and thank you again.
Thank you, Dr. Yousefi, for this concise presentation about understanding how NIRS works. Our next speaker is Dr. Gabriel Altit, and it is my pleasure to introduce my colleague. So Dr. Altit is one of our neonatologists in Canada. He works at Montreal Children's Hospital, McGill University on Quebec side of Canada. So he's a French speaker, English speaker. So Dr. Altit is one of the neonatologists who took the direction of working on neonatal hemodynamics after his training in neonatology, pediatric neonatology, and at McGill University. He went in and did postdoctoral research in Stanford University in echocardiography, and came back to Montreal, and he established a fellowship and service for neonatal hemodynamics and targeted neonatal echo. And since then, he is one of the main physicians who are taking over the neonatal hemodynamics. And as you will see in his presentation, he will talk to us today about using NIRS in congenital heart disease. Welcome, Dr. Altit, and you can take it from here.
Thank you so much, Dr. Ben-Fidel. It's really a pleasure and honor to be here today with all of you and to be able to share some of my research and some of the experience I gained in the use of near-infrared spectroscopy. So I really want to thank the organizing committee and the POCUS NEO team for inviting me and thinking of me to present this. So I will be sharing my screen now. I believe you should be seeing now my slides. So today I'll be speaking a bit about near-infrared spectroscopy, actually in the field of congenital heart disease, which a lot of the work has been done in collaboration with my team of pediatric cardiology and neonatology for the research projects that I'll be discussing. And I want to thank the previous speaker for outlining so well the grounds of what are the principles for the use of NIRS. So these are my disclosure. One of the research projects that I will be speaking of today was done thanks for the research grant I obtained from Medtronic, who provided NIRS sensors and monitors to do this study at the Montreal Children's Hospital, but they had no say in the protocol or the design or the actual data analysis or interpretation. So today we'll speak about understanding some of the principles. So I will do a bit of a repeat from just to consolidate the knowledge on what NIRS informs us. We'll talk about some of the evidence in the context of congenital heart defects, specifically to the neonatal population. And we'll talk about some of the results of the ongoing studies. So I'll be speaking about congenital heart defect, but I want to remind ourselves that the babies that we care for in the NICU, they're all going through a very vulnerable period. They're going through a vulnerable period of transition where, regardless of the underlying diagnosis or condition, we know that going through this transition can be sometimes disturbed by prematurity, by congenital heart defect, by asphyxia, sepsis, or other type of disorders, because we know that some of these patients may have, first of all, this natural transition of drop in pulmonary vascular resistance and rise in systemic vascular resistances that does not occur as smoothly as we would like it to happen in the context of these stressors. And some of these patients may have persistent fetal shunts, which on top of it may contribute to some of that instability in that transition. So for example, we know that some patients, especially those with congenital heart defect, we might artificially keep some of these shunts open, which may contribute to this imbalance between what's happening on the systemic side and what's happening on the pulmonary side. And for all of these populations, I do believe that one of the main goals of care in intensive care setting is to maintain adequate perfusion and oxygenation of some of these vulnerable organs, the brain, the heart, the kidneys, the gut, in the setting of all of these changes that are occurring in this transitional period, especially when there's added pathological conditions. And so what does near-infrared spectroscopy informs us? I think it was very well outlined by my preceding speaker that it informs us on what's happening in the venous compartment. And it's basically an information about the venous weighted saturation of the hemoglobin. And so hemoglobin, we know, is something that transports oxygen. It typically has 4 spots on it to bring in oxygen. And so if those 4 spots are taken, we're saturated at 100%. And if 3 spots are taken, then we're saturating at 75%, et cetera, et cetera. And it's the mean average of all of these hemoglobin that are passing through that captor that is being brought to us in terms of the information. And so when we're looking at a NIRS value, we're actually looking at a reflection of what's happening in that venous compartment to some degree. And because the venous amount is dependent on so many factors, I think the value that we do get at bedside needs to be taken into account of what's happening in terms of local perfusion, systemic oxygenation, what's the vascular kind of tone of this patient, which may be influenced by CO2, what's the metabolic rate, so is there an increase or decrease in that metabolic rate, and what's the type and concentration of hemoglobin that we have in that particular patient. And so because in some of these patients, many of these factors may be stable, we try to use NIRS as a surrogate of what's happening in terms of oxygen delivery and brain perfusion, because venous weighted oxygen saturation is actually a reflection of cardiac output and oxygen content. And so if these are remaining stable, then possibly this venous weighted saturation is a reflection of the output or the amount of perfusion coming to the tissue that I'm actually monitoring. So I do like the analogy of a highway. Why? Because I think that vessels are highways. They're a huge network of different routes in which our little hemoglobin, which are little cars, are transporting these oxygen saturated at 100% when they're containing 4 spots of oxygen, The little car goes in front of the brain, and the brain or the tissue that you're actually monitoring is extracting this oxygen. And you end up with a little car in the venous compartment that gives you 75%. I'm very happy that we have a consistent message amongst the different presenters. And this whole process may be affected by many things. The motor could be a problem, and so my car might be going very slowly. And so if all these cars are going very slowly, then the brain, who still needs that oxygen, might extract more of that oxygen as these little cars are going through very slowly. So little oxygen passengers are coming out, and maybe this will be reduced because of this effect of low cardiac output or low perfusion. But it could also be an effect of metabolic demand. So if, for example, this brain is seizing or is having a high metabolic rate, in hyperthermia conditions, for example, you might extract more. If some of these vessels or some of these highways are blocked, well, the other highways that are able to perfuse the brain might be used to extract more oxygen. And so whatever you're going to read in your venous compartment will be lower. So you can think of, for example, vasoconstriction and tone issues. You can think of disruption of the vessel, such as a vessel that's broken and bleeding, like an IVH. It could be blocked. So if you have thrombosis or disseminated coagulation that's blocking some of these vessels. And in the end, obviously, not all the cars are made equally. So, all these different brands of car might be doing things differently, like might have a motor that's different or might accommodate different types of hemoglobin structures, might have different affinities for oxygen. So you can think about adult hemoglobin that we transfuse in some babies versus fetal hemoglobin, as well as some of the hemoglobinopathies, and as well as the amount of absolute hemoglobin. So if you have 2 little cars driving into the highway, it's going to be very different than if you have 10 cars driving on the highway. There's much more oxygen being transported. And so I think one of the key points is that NIRS informs you on the degree of oxygen extraction, but has always to be placed into relationship with all of these elements. One of the things we'll be talking about today is a concept called fractional tissue oxygen extraction, which is really the relative difference between what's happening in your arterial compartment to what's happening on your venous compartment as translated into a saturation measured by NIRS. And so we typically will look at this value as a reflection between the oxygen delivery and consumption, and informs you about how much got extracted during this whole process I just explained. So typically the FTOE, or fractional tissue oxygen extraction, is estimated using the systemic saturation, either the pre or the post-ductal, depending on the territory that you're evaluating, compared to that value of the NIRS divided by this arterial oxygen saturation. So we spoke about these different parameters that need to be taken into account. And I think that in congenital heart defects, there could be many setups where the cardiac performance may be abnormal. The local blood flow may be affected by a systemic steal from the systemic to the pulmonary circulation via an open ductus. There could be changes from the perfusional status to these brains or to these kidneys or to these various organs because there's different heart defects like coarctation or valvular stenosis or other types of congenital heart defect that may impact these values. And of course, there's all these other things that may also affect congenital heart defect and that we hope to adjust to avoid local hypoperfusion in the context of these patients with a precarious anatomy. You can think about anatomical variability of vascular structure, clots that may happen to the brain after certain procedures, for example, like septostomies. We can think of bleeds or vascular integrity that could be happening. These babies may be at risk of issues with their hemoglobin dissociation or dyshemoglobinemias, depending on the drugs that they're being exposed to. They can have underlying issues like hematoma after deliveries that might be more difficult, or they can have fasciculation at the superficial areas. So when you see some of these various NIRS values tanking down, you need to think of all of these other potential artifacts that may be happening. Blood pH may affect vascular tone as well as CO2, vascular permeability and hemoglobin content, and obviously metabolic demand. And so I do think that it's important in general, whether that you're using this technology for research or clinical use, to look at the trends, because it's really drops and increase that will provide you more information of what's happening underlying, and looking at all these various factors to have a better sense of what the value is telling you at bedside. So that's a quick study that was done where they took animal models and actually ligated the brain vessels versus the renal vessels or versus the mesenteric vessels. And what they saw is that the NIRS values continue to remain very steady for all of these vessels that were not ligated, but actually the NIRS values for the brain dropped and became back to normal after deocclusion for the carotid arteries. Same thing for the renal arteries, and same thing for the SMA arteries. So I do think that this was a nice animal model showcasing that there is a reflection of perfusion to renal, somatic, or brain NIRS correspondence. So what about the congenital heart defect? Well, we have a body of literature that's been already published in the context of cardiac surgery, either during anesthesia or after the post-op recovery phase. And for example, we know that NIRS can be used in detecting some of these catastrophic events of cannula misplacements, where suddenly during anesthesia, you get cannula misplacement and tanking down of the NIRS values in order to recognize these events very quickly during anesthesia. We also know that during a coarctation repair, there's some studies showing that the renal saturation will decline when you're doing some cross clamping, showcasing that there's probably low kidney perfusion. But there's also evidence that depending on where you put your cross clamp, proximal or distal to the carotid arteries, you may see different effect on the brain, which may help us decide on the approach to repair. In the adult population, we know that there's trial evidence that the monitoring of cerebral saturation during coronary artery bypass will help detect some moments of cerebral desaturation. And by just doing the monitoring in that particular adult population, we do end up with less major organ dysfunction in the recovery phase. And as a proof of concept, there's been a study actually sampling the internal jugular vein during cardiac surgery of children and found to have a close correlation with the actual hemoglobin values of the venous saturation to the cerebral saturation that were obtained during that surgery. And so just to say that obviously we don't have a lot of trial evidence in the context of the neonatal population, but I'll try to go over some of the evidence that we currently have, at least for the preoperative phase, where these patients are at risk of transitional disturbances. So that's one of the pediatric population, looking at the association between the prognostic value and the context of congenital heart surgery in infants. These were 41 neonates undergoing bypass. And first of all, they saw that applying the sensor to the left versus the right cerebral saturation basically were equal, telling us that probably just monitoring the frontal lobe would be sufficient to get some sense of what's happening underlying. And what they found was that perioperative values that were in the low extremes, so cerebral saturation or renal saturation below the values of 45 or 40%, actually was associated strongly with the outcome of ECMO or mortality. And values that were very low for renal sat was associated to prolonged ICU stay. And so whether improving these values would change these outcomes require a bit more research to be done, but at least we already have strong signals that these values may be associated with adverse prognostication. There's another group that looked at single ventricle, here hypoplastic left heart syndrome. It's a fairly large population of more than 200 patients. They did a monitoring for 48 hours after the operation of stage 1 palliation. And what they found was that cerebral and renal saturation were, first of all, much higher in the survivors, but also predictors of mortality that was early and for the use of ECMO. This other group did a prospective study where they looked actually at the outcomes of neurodevelopment. So they actually went way beyond the neonatal period. They had 54 patients that survived to follow up. And when they pooled those that had an outcome of mortality and those who had follow-up, they found that a large portion of these patients had adverse outcomes, looking at their Bailey score, looking at the mortality. And these poor outcome patients were those ones that had very low values of cerebral saturation at the immediate timing in the post-bypass period and at 24 hours post-bypass. And I think you can see that these are values below 50% for those patients who had poor outcomes. We looked at our own population when I was at Stanford as a postdoc fellow. We actually looked at the single ventricular physiology during the first 72 hours of life. And the primary objective of this study was to actually see if there were patterns that would be different between these different physiologies, which we would expect, as well as differences with a small group of controls. And what we found is that, first of all, in the first 72 hours of life, regardless of the underlying physiology, either hypoplastic left heart or tricuspid atresia or pulmonary atresia and tach-septum, these patients had progressive drop in their renal saturation, probably because of the consistent steal that's happening as these pulmonary vascular resistances are dropping. The other thing is that you can see that their oxygen extraction for the territories of the brain and the kidneys kept on creeping up, telling us that there was more oxygen extraction happening as time went along. That could be because the brain is requiring more metabolic demand, but it could also be a reflection of the fact that the perfusion is becoming more challenged by the fact that these patients have an underlying cardiac disease and potentially some steal from the systemic circulation. When we look at the controls, you can see that the cerebral sat and renal sat were drastically different and much lower in the groups of patients with congenital heart disease. Same thing, the oxygen extraction were much higher in both the renal and the cerebral territories. And there's another group that published in the first 3 days, 4 days of life and divided them as per the cardiac physiology, seeing that there's different effect of different types of cardiac physiology in the immediate postnatal period. Now, recently, this is Carolina Michel-Macias, and Dr. Michel-Macias was one of our fellows in hemodynamics. And actually, she got interested in looking at some of our own data of a prospective study we've done at the MCH. We actually were again interested in looking at the population of newborns with congenital heart defect that were admitted to our NICU. And we actually did echoes on these patients for the first 7 days of life and followed their cerebral and renal saturation to try to better understand if the effect of pulmonary vascular dropping would really, increase the tendency to have dropping cerebral or renal saturations, as a proof of concept that there might be a perfusional disadvantage to these patients with some degree of retrograde flow into the aorta. So we wanted to describe cerebral and renal saturation trends in the first week of life, and we wanted to compare the patients with presence or absence of diastolic steal before they underwent surgery. And our hypothesis was that, well, we felt that having a diastolic steal would potentially lead to adverse cerebral and renal saturation, possibly indicating that these patients have altered perfusion within these territories. It was a single center prospective study. We enrolled patients that were more than 34 weeks, and we monitored cerebral and renal saturation for the first 7 days of life. We looked at the last available research echo, and we divided the population based on the presence or absence of retrograde flow in the descending aorta to see who did or who did not have a diastolic steal in these patients. We ended up with 49 patients with various types of physiology. Majority were coarctation and DTGA. And as you can see, we had about half of the population with non-retrograde aortic flow compared to half or 27 patients that had retrograde aortic flow. And so these are the trends over the first 7 days. The one in reds are those that are non-retrograde, and the one in blue were those that are retrograde. And right away, you can see that they have dropping cerebral saturations in time. And those with retrograde flow have an average much lower cerebral saturation and renal saturation compared to those who did not have this retrograde effect in the aorta. So this tells us that there's probably an effect of having this diastolic steal in these patients regarding the amount of perfusion or oxygenation that's going to their brain. The other thing is that you can see that while the renal oxygen extraction remained pretty parallel, which tells us that probably the kidney is not extracting that much oxygen regardless, because it's not an organ that may need that much oxygenation and blood flow. The cerebral oxygen extraction was much higher in those patients that had retrograde flow compared to those that were not having this retrograde flow. And this was quite striking on some of the models. So this is a random mixed effect model where we saw that there was a clear association in the cerebral oxygen extraction, cerebral and renal saturation by NIRS in terms of having retrograde flow in the descending aorta. And so we felt that these patients had a more profoundly decreased values of NIRS, which may outline that the ductal steal phenomenon that they have may impact the perfusion of these organs. Dr. Piscini-Canaprash is our current hemodynamics fellow. What she looked at was this population of congenital heart defect, and she wanted to see if some of the markers of brain perfusion were associated with some of the markers of NIRS. So again, she looked at the cerebral saturation and the oxygen extraction, and she actually went back and looked at all the anterior cerebral artery Dopplers of these patients. It was again a prospective study. We did Doppler ultrasound of the brain every day during hospitalization until day 7, and we extracted the cerebral and preductal saturation at the exact time of the Doppler of the brain. So this is an example of the Doppler of the brain of the anterior cerebral artery. These are the parameters we look on the Doppler as a marker of Doppler perfusion. And we went back and retraced at the exact timing of when this was acquired, what was the value on the cerebral saturation. So she had 34 patients in her cohort that had both Dopplers of the brain and NIRS values at the same time. And what she found was that the values of the resistive index, which as resistive index or pulsatility index increases, you get more resistance of blood flow in your brain. She found that there was a direct association between these values and the values of cerebral saturation and cerebral oxygen extraction. And so in conclusion, for this particular sub-study, our data indicates that lower cerebral NIRS values and higher cerebral oxygen extraction actually corresponded to the higher instantaneous values of resistance of blood flow in this territory of the artery that actually supplies the frontal cortex, which is the zone where we measure NIRS. The last quick sub-study I want to mention is Dr. Marina Mir. She's now a pediatric intensive care physician at McMaster University. But during her stay with us at the Montreal Children, she actually studied 15 patients. In the post-op period, she actually found a similar signal. She looked at the resistive index, and this is unpublished also, but she looked at the resistive index and the pulsatility index, and she correlated that with the immediate cerebral saturation. And she again found a similar trend in terms of association. And so that's kind of a proof of concept for me, telling me, well, whatever we're measuring at bedside really reflects what's happening underlying in terms of the vascular perfusion. Quickly, I want to speak about implementation at the MCH. You have a QR code in my slide that's available. It will bring you to our bundles and packages that we have locally implemented for our own population. And obviously, you have to adapt this to your own practice, to your own teams, and to your own review of the literature and how this can be useful in your own setups. Here we have some of the guidelines that we've implemented thanks to the work of the multidisciplinary team. I see, for example, Leila Wesney on the line, who's one of our nurse practitioners who worked very closely with us to work on this. And you'll find videos on how we implemented NIRS in our unit and in our own reality. You'll also find some of the population that we chose to start monitoring in our context. So we do monitor patients with congenital heart defect, and now we also monitor patients with hypoxic ischemic encephalopathy during therapeutic hypothermia and rewarming. And so at every bedside, we did implement quick cards for our nurses. So that, if you remember, the values of 50 was kind of a value that was of concern for the congenital heart defect population. So they do call us when they see that in the preoperative setting. But they also go through the quick algorithm of what could be the reason why these values are low, and is there something that we actually could address as a bit of a red flag? So is my value low because my patient is hypoxic in the arterial compartment? Is there a concern for hypotension or shock or poor perfusion? And so we need to check some of these elements. Is my patient anemic, and what was the last hemoglobin? Could there be low carbon dioxide causing cerebral vasoconstriction? Is there concern that my patient may have increased metabolic rate, and could there be any other underlying condition explaining this? And so you will find in some of the resources that I put online some algorithms of why values could be below 50% or dropping, or why values could be at the other extreme, which is on the high side, which could also be of concern. A quick example of one of our own patient population. Here, this is an example of a patient who was admitted initially with a concern of coarctation. And in the end, there was a decision to try to stop prostaglandin because it was felt that the arch was not too much of a concern. But in that same evening, we had a massive drop in the renal saturation. And it was decided to actually maintain PGE and not stop it. And actually, we saw, big switches, big changes, like values above 89%. And the next day, we recontacted our cardiology team. They came, they reevaluated, and they saw actually, okay, no, this patient has a significant coarc and needed to be brought directly to surgery. Sorry, let me go back. This is another patient where we slowly saw a drift in both the cerebral and renal saturation. The team was called when the values were starting to get closer to the 50% baseline. And eventually, 3 hours later, was in fluid septic shock. But actually, the team noticed that way before and started implementing some of the strategies a bit earlier for this patient who ended up being bacteremic with a congenital heart defect. And you can see that the values progressively went back to normal as the shock status got improved. So in conclusion, I think that NIRS may be a valuable tool in monitoring infants at risk of hemodynamic changes, such as the context of congenital heart defect. We do need more data. We do need more studies to establish important thresholds of concern in specific neonatal population, as well as to test some of the management algorithms, which eventually I'm hopeful will translate into improved outcomes of perfusion to the brain, less brain injury, and hopefully better neurodevelopmental outcomes in some of these patients. I do want to remind you that trends in time are important and that absolute values need to be put into the context of the overall status of patients. And some of the studies we actually did hopefully convinced you that cerebral saturation does reflect some of the ultrasound parameters of blood flow. So thank you for inviting me, and I'll be open for questions or comments at the end of this presentation.
Thank you. Thank you, Gabriel. It's a fantastic presentation. I don't know if there is any technical issue with Adil or Nadia. Can you hear me, Adil, Nadia?
Yeah, I can hear you.
Oh, okay, thank you.
But I think Adil is going to come in.
So just for, I know Gabriel has another symposium webinar. You need to jump to another one. And if anything from the moderators, anything specific that before he leaves, if you need any question.
Yeah, there is a question in the chat. And the question is, do you have any data on preterm babies with PDA to know that if it is hemodynamically significant or not?
It's a very good question, and I do want to apologize that I have to leave at 12:45 for another session, which is called Scientific Preemie Chat from the Canadian Premature Baby Foundation, which starts at 1. Basically, we locally don't necessarily put the NIRS on premature babies, but there is data, and a lot of the data coming from the Stanford group, the group of Dr. Valerie Chalk, who is one of the experts on the field of monitoring with NIRS and studying NIRS in terms of a metric that could be of interest in some of our precarious newborns. And what she did show in her cohort was that patients with large ducts with retrograde flow, left to right shunts in the context of prematurity were babies who had much lower renal saturation. And actually, there's a paper we did, there's two papers that we published when I was at Stanford with Dr. Chalk as a mentor, where we outlined that actually when you look at the ultrasounds of these patients who have had ultrasound and you look at the resistive index and you look at the pulsing index, they actually match what you see on the cerebral NIRS. And same thing when we looked at the aortic Dopplers, we found a correlation between the aortic Doppler and what you have on the renal NIRS. So it's not surprising to see that when they have a lot of ductal steal and a lot of steal to the kidney, this renal saturation will drop simply because they get less blood flow coming to their parenchyma. And so it doesn't say that it's necessarily hypoxic because the kidney might be able to kind of auto-regulate, but it might be an indirect sign that there's an ongoing steal phenomenon. And I do know that the team of Stanford published a lot on that.
Thank you. Maybe if the time permits, I have another question for you from some of the questions that were submitted.
Absolutely.
It's purely for congenital heart disease. So the question is, in the setting of HIE or congenital heart disease on ECMO with low dynamic and hemodynamic process, how can you tease out PDA or left ventricular failure while using NIRS?
Yeah, so, I think, and maybe Dr. Faruqi also will be talking and presenting on this, but I think the way I see it, NIRS, like heart rate or blood pressure or saturation, is part of the equation when you're trying to address a patient at bedside. History, physical exam, all these elements, they have to be kind of combined together to tell you the story, right? And that's why we are a physician, because we come to the bedside, we hear the story, we do the exam, we send maybe investigation that we think are pertinent if they're needed. And for me, it's the same thing, especially a kid who's going towards ECMO or is on ECMO. There's so many physiological variables, and I think NIRS comes to inform you when there's red flags, when there's trends that are abnormal. And then you have to put it into context. And so will NIRS tell you, oh, this is because there's a ductal steal, or this is because the LV performance is greatly affected? I think for me, it's when there's a drop or there's a trend that's kind of going into a direction that is of concern, to try to go to bedside and put the information together. And maybe this patient, once is being signaled to you, well, you need to actually perform a more in-depth evaluation, like an echo, if you think that there's a concern. So if you see a baby that has dropping blood pressure, dropping NIRS values, increasing oxygenation, lactator getting worse, the story is telling you a lot. And I have seen, at least in my experience, some babies where these values of NIRS at bedside are starting to change earlier before you get these actual clinical, drops. So, and that's the goal of these, augmenting the way we monitor these patients, is to avoid getting to the point where you get end organ ischemia and organ damage. By the time your lactate is up, it means you already have a hypoperfusion process. So let's try to get it before this happens.
Thank you so much, Dr. Al-Tit. So now I'm gonna, we may have more questions for you after.
Nadia, can I say something?
Yeah.
Thank you, Jabrail, for excellent presentation. I go with Jabrail, even though as Dr. Jabrail mentioned, Hoffman also presented the same thing during cardiac surgery, more fluctuation in the blood pressure, and those having more hypoxic injury. One question for you, Jabrail. Recently 2 cases with post-cardiac surgery, there were more hypoxic insult for the worst kind of MRI. So do you recommend to have more vigilant for cardiac surgery cases, to low threshold for the MRI, Because this has happened recently, a couple of cases in our institution.
Yeah, I can only speak about our own experience, and I know that our institution, we've implemented in about 2019 the routine use of NIRS for all of these patients from the moment they're admitted to our ICU, during the operation, and in the post-operative phase. So they're all monitored. They're obviously monitored not just with NIRS, they're monitored with so many other elements. And we see it as a way to trigger red flags, right? So in these three contexts, in the pre-op or pre-interventional, during the intervention, and in the post-intervention, when the near trends are becoming abnormal or they're hitting certain values of concern, the medical team is being alerted. And then the medical team comes to bedside and they actually assess the overall picture of the patient. And I can only talk about our own institutional experience, and hopefully soon some of the publication will come out of this subgroup. But we see that in our population, actually the rate of brain hypoxia on MRI and some of our long-term outcomes are very good. We have very low amount of degree of brain injury on MRIs. We have good outcomes in a lot of our patients in terms of follow-up. And whether it is the whole package of the way our things are being done versus, you know, the different types of strategy that we've implemented to try to avoid having some of these hypoxic events, I think it needs to always, you know, come back to QI processes in your own institution and training your teams to really integrate some of these augmented ways to assess patients at bedside. I hope it answers your question.
Is there time for one more question?
Sure.
I think Gani has said there is time for one more question before we proceed to the next speaker. Okay. And Gabriel, I'm going to ask this question for all the speakers and also the panelists. Maybe if you have time to have some discussion at the end, but because you're leaving early, I want to bring it to your attention. We know that there is some limitation of why NIRS after maybe close to 2 decades of research and trial did not come as a standard of care in many settings, not only middle and low resource settings, but also in high resource settings. And this limitation comes sometimes from the level of evidence that we have. It's mostly single center trials with expertise group, and there is lots of heterogeneity in the trials and the population, the intervention, the machines used, and the disappointing results of the SafeBoost trial. And I'm going to put here in the chat, I know that everyone has probably gone through this report from the European Pediatric Research Society with special interest group in NIRS on what to do next, how we can bring it to the bedside, and what we need to have the evidence building. But I think the title of today's webinar is very informative. Is that do we need more evidence, or we need to consider it as a 6 vital sign, like you mentioned, put all the informations together to guide clinical decision making? So from your point of view as a researcher, what will be your intake on that? Do we need more evidence, or do we need more implementation?
Very good question. And I'll try to tackle this question in a few fronts. I think number one, as a researcher, I'm always going to tell you we need more evidence, because I think research is always important. And I think we should always question ourselves, even into deep-rooted practices that we're convinced about. We should always question, is that the best way of doing things? If not, we don't progress. So I will answer that, of course, we'll always need good evidence. I think that one of the concern or issue that comes up is that with always new ways of augmenting the way we monitor these very fragile and precarious babies we have at bedside, we're not talking about like a therapy. We're not talking about a drug. We're not talking about an intervention. We're talking about a way to augment the way we monitor, right? And as I hopefully outlined in my talk, this monitor provides you an information at bedside that is continuous, that is complex, that needs to be integrated in your clinical pathway in a systematic way. And I think there's a lot of groundwork that needs to be done, the same way that some of our speakers outline how they integrated this in their unit. There's a work that needs to be multidisciplinary with the nurses, with the colleagues and peers and the trainees to implement this as a way to integrate this in your clinical pathways if you do decide that it's something that's going to be important for you. We actually started with research and quickly realized that this was something that was a benefit for some of our very high-risk population. And so progressively, what was very research-oriented became something that was very valuable at the bedside to study some of the most high-risk patients. And so I do think that, you know, depending on the reality of the types of resources you have and, you know, the interest of developing an expertise in your local unit, I think it's important to stay aware of the research. And I think it's important to be aware that a tool that you monitor a physiological parameter needs to be put into context. So for example, same thing with heart rate, same thing with blood pressure. We all know that blood pressure measurements, like a value, one specific value for a baby, may be a big red flag, but it's also maybe not. Maybe a baby who's born at 27 weeks, who has a mean blood pressure of 26, is completely in a physiological state that's completely balanced and doesn't need to have like inotropes or significant intervention. But maybe another baby that had 35 of mean blood pressure for the last 6 hours and ends up with 22 for the next hour, maybe there's a red flag there. It's very hard to study this in trials, right? Like for trials, you need to have a very specific exposure and very specific outcomes that you're measuring. And sometimes we don't even agree on the outcomes that we think are meaningful, right? What are we trying to prevent? Like the mortality, the brain injury, the neurodevelopmental outcomes. So these are so multifactorial. So when you're trying to study and monitor to tell you, oh, that's going to improve, you know, the rate of getting to school at 5 years, there's so many elements that come with it. And I think as we're going towards a more precision medicine, it's important to get the data. It's important to get the information at bedside. And I'll just finish with the Safe Boost, which I think was a very big study and very important study. It targeted a population of babies that were preemies, less than, you know, 28 weeks. And it's the first 72 hours. I don't believe that the story of a patient is limited to the first 72 hours. I think the first 72 hours are very important. But imagine I told you today, you know what, we're going to monitor the heart rate, the blood pressure, and the temperature for the first 72 hours of a baby born at 23 weeks. And then we're going to stop monitoring. We're going to leave this baby, no heart rate, no BP, no saturation, no. I don't know that this would be a standard of care. And I'm not sure we would have the equipoise to do that kind of things to the baby. And maybe actually that would be better, who knows? But no, I cannot believe that there's any unit that would accept doing this because there's not a study that proved that monitoring heart rate is good after 72 hours. But that's my own bias and perspective. I do think we need more research. We need more good research. And it's by doing initiatives like we have today, connecting the world together and trying to better understand what this tool is telling us at bedside, that we're going to be mounting the multicentric studies and that we're going to be able to showcase, hopefully, that we're improving the way we're doing precision medicine. But that's my little biases on the current practices and literature. I hope I answered your question.
Well said, Gabriel. Thank you.
Thank you so much, Gabriel. Excellent presentation, and thank you for your time and the question that you addressed. Now the time to introduce our next speaker. He doesn't need introduction, but all of you know Dr. Yasser Sayed. He's around with his excellent presentations as always, but I'll give very, very brief introduction for some of you who might not know Dr. Sayed. Dr. Sayed is Associate Professor and of Pediatric and Staff Neonatologist, University of Manitoba. He's a dedicated researcher at the Children's Hospital Research Institute of Manitoba. And as you know, Dr. Sayed is the founder and director for the Integrated Hemodynamics Program and Point of Care Ultrasound in Winnipeg. He co-chaired with Dr. Ghani the Focus New and New Beats Academy, and has conducted over 50 workshops globally in the past 5 years. The research focused on the hemodynamics and physiology-oriented practice. He was the co-chair for the Canadian Neonatal Perinatal Research Meeting in 2020. Please join me to welcome Dr. Said Yasser. Stage is yours.
Thank you very much, Dr. Adel Muhammad. That's a really wonderful introduction to me and really kind of you. Welcome, everyone. And my presentation today about near-infrared spectroscopy and hypoxemia. I hope that you can see the slide.
Yeah, sir. We can see.
Can you hear me well and see the slide?
Yes, we can hear you well.
Okay. So I will be talking about hypoxemia, but I have to start first also with some background which might consolidate the wonderful previous two presentations that consolidate the knowledge on the basics of near-infrared spectroscopy presented before me. So I have nothing to disclose in this presentation apart from Medtronic supported this event, but it was an unrestricted educational grant. So Medtronic has no any contribution to scientific material presented here in my presentation. In my presentation over the next 30 minutes or so, I hope that you will be able to answer these questions. I have 4 specific questions, which will start with: does near-infrared spectroscopy monitoring improve outcomes in NICU? The question that was asked by Dr. Jaher Afifi and Dr. Gabriel Altit answered this question wonderfully. It was a wonderful answer, but I'm going to throw the answer again with some slides and some data. Then the second question: how can NIRS be a vital sign? Now we have 5 main vital signs in ICU or in intensive care, including blood pressure, temperature, respiratory rate, heart rate, and oxygen saturation. And should we add the 6th vital sign? Is it really adding a lot to our monitoring data on daily basis in sick infants? Then the third question: what are the indications in general? But I will be talking more about hypoxemia and how we can benefit from near-infrared spectroscopy in hypoxemic infant, either hypoxemia due to parenchymal lung disease or heart disease. So let us first answer this question: does NIRS monitoring improve outcomes in the intensive care? Let us actually talk about the history of medicine for the last decade. Long time ago, probably before our graduation or most of your graduation, we were relying on intuition medicine, like looking at textbooks and also relying on the experience more than anything else. That's before the era of the evidence-based medicine, which was started actually in Canada, or specifically at McMaster University in early 1990s. So before that, we are just relying on symptoms and signs and looking at textbooks and have our knowledge based on our colleagues' previous experience. And then the present era, which is still relying on evidence-based medicine. And I'm talking specifically about clinical trials. So select a group of population and randomize them into giving intervention to one group and giving different or no intervention to other group. Randomization, talking about evidence-based medicine and randomization, clinical trials. The main limitation of this approach, which is really wonderful approach, assuming that every patient is the same. So assuming everyone is the same and we just randomize to very specific intervention. I'm talking about intervention, not just using monitor and using any other kind of application to be randomized. And unfortunately, over the last 30, 40 years, we have been abusing this concept and using the clinical trials. So everything that should be only restricted to specific interventions, assuming that every patient is the same, but was not the case. That's why now we are moving a little bit more to the precision in medicine and algorithms. that's more physiologic based in the situation that we don't have the population is the same. If we have a population which is heterogeneous population or disease which is heterogeneous, then we have to adopt another strategy, precision in medicine, or using algorithms. Near-Infrared spectroscopy is more fit to this category. But let us talk more about that. So practice in medicine, we have now two different kind of research, and we have to respect that. We have the physiologic algorithms, and most of the studies presented by Dr. Al-Tiet in the previous presentation based on the physiologic algorithms, based on the physiologic concepts, and talking about hemodynamics and how to use monitor to understand more about the blood flow. And on the other hand, we have evidence-based intervention, assuming that everyone is the same. Again, in the other arm, we have everyone is different. So for the last 40, 50 years, how many answers do we have? Only very few, even less than 10. We know that very few interventions that we are using in NICU are good for outcomes. Not more than that what I have listed here. I'm talking about the big outcomes: CPAP and avoid mechanical ventilation, breast milk and avoid formula, skin to skin, encourage more skin to skin, and kangaroo care and family integrated care, delayed cord clamping, antenatal steroids, surfactant, caffeine, and cooling for HIE. These are the outcomes that we know that's contributing almost less than 10% of our interventions on daily basis, and the evidence left us with 90% unanswered questions. And the 90%, we have two options: either to rely on physiology and very specific physiologic algorithms, or just empiric therapy, just apply whatever trial and error to whatever we do. So everyone is different in pulmonary hypertension. We have so many phenotypes of pulmonary hypertension that they are not all the same. We cannot give nitric oxide to all of them, or we cannot give plenty of oxygen to all of them. PDA shunt, that is also heterogeneous. Not all the PDs are the same. Shock, we have multiple phenotypes of shock. Neck, one of the most misunderstood disease in NICU, and we don't know exactly what we are doing in neck. Hypoxemia, which is our topic for today, and ventilation support, which is a big kind of mess still in a lot of intensive care practice, abusing ventilation or keeping ventilation for a long time, and that might contribute to poor outcome. So every patient is different regarding the ventilatory support. We cannot just make the ventilatory setting everyone is the same. So what do I need from near-infrared spectroscopy? So if I cannot use it as an intervention tool and randomization, what I need to do, what I need to know, or what I need to get from NIRS? Improve brain outcomes. Am I expecting this machine of monitoring to improve outcomes, to make babies in the future smarter, detect physiologic changes in the cerebral oxygen, or guide to more specific interventions to improve brain oxygen, or B and C? I think you agree with me, B and C. I'm not expecting a monitor to improve outcomes. The same as mentioned by Dr. Al-Tiet, I'm not expecting monitoring heart rate every day to improve outcomes. That's really not really appropriate question. Or monitoring temperature. Because we are relying on the intervention, which is the second step, not on the monitor itself for the randomization. In this study, which was highlighted also during the discussion, the Safe Boost study, randomization in preterm infant during the first 72 hours of life, which is only 72 hours, just 3 days of premature life. We got actually very good knowledge out of this study, which is we know that when you randomize or when you use near-infrared spectroscopy, you can decrease the burden of hypoxia or hypoxemia compared to blinded NIRS. You are using NIRS without intervention. And that's the full stop. That's what I need. I need from the monitor to maintain or let me know about the oxygen saturation, and certain intervention needs to be done based on that. I don't need from the machine to change big outcomes in the future. And that's actually a waste of time trying to prove that a monitoring technique will improve outcomes. The same actually applied to T in echo. I cannot assume that randomize using T in echo to improve outcomes. That's not really appropriate question to be asked. I cannot randomize patient to any single different monitoring technique. Do we have evidence that using a stethoscope every day in the unit improve outcomes? These questions are not appropriate to be answered by randomization. So we should not expect improved specific long-term outcome by monitoring a vital sign. That's not really appropriate question to be answered by randomization. Monitoring vital signs may lead to a specific interventions to maintain end organ performance. That's it, full stop. That's what I need. Randomize relying on a vital sign. I'll just give you an example here. 2 weeks old preterm with high temperature. That might happen almost on a weekly basis. You may have preterm infant with suspected sepsis, which could be environmental, could be real sepsis, or could be meningitis. So you may, as a person in the unit, consider antibiotics. So your personal decision. So I cannot randomize that relying on temperature or not improve outcomes, because it actually relies on your personal decision, and also not only your personal decision, and also rely on resistance. Is the antibiotic that I'm using to treat the sepsis or meningitis has a resistance as an individual response? And I have the third level. Even if the antibiotic is effective, is there end organ compensation to septic shock? So the infant might develop septic shock and might recover from sepsis, might be end organ damage in the future. So it is not about the temperature that I'm using, it is about other different levels of interventions and responses. Response from the patient overall, response from the medication itself, and response from the end organ. The same like cerebral oxygen saturation. I have 24 hours preterm with low oxygen saturation. It could be due to anemia, hypocarbia, and hypotension. It is my personal decision. I may ignore it. I may order blood gases to know that there is hypocarbia in real time, or check the blood pressure, or I may just ignore it. It also the individual response. If the infant responded to the intervention or not, and then the organ compensation might be different. Not all premature infants might respond to the intervention. I may adjust the mechanical ventilation to recover from hypocarbia, but not all of the brain of the premature infants are the same in response to autoregulation and compensation. So it is very complex way to get a clear answer from randomization. What I need from the machine to monitor the brain oxygen saturation and to give me a number that I may react or consider intervention based on that. And full stop. That's what I need from any vital sign monitoring. Okay, so now let us answer the second question. How can NIRS be a vital sign? I mentioned about the 5 main vital signs. The last one with the oxygen saturation, which was implemented as a 5th vital sign in late 1990s. And imagine it was actually difficult for most of our colleagues, ex-colleagues in intensive care units to buy in the idea of adding it as a monitoring tool. The same as we are now arguing about near-infrared spectroscopy. Simply, we have the arterial blood here. Just to simplify the idea, it was really simplified very well by Dr. Samer Yousfi, just to consolidate what was discussed in the first presentation. We have the arterial oxygen saturation presented in the arterial blood, and the arterial blood only 15% of the overall circulation. We have 75% or 80% of the circulation as venous blood. So the huge volume of blood compared to the arterial blood. That's why it takes longer time for the saturation on the venous side to be compensated and the change. And the arterial saturation change very, very quickly based on the changes in the lung expansion or any other factor that might affect oxygen saturation. So the brain consumes part of it. So 4 conditions for normal oxygen consumption. So the brain should consume, or any organ in the body should consume certain amount of oxygen based on the healthy brain or not. Like it could be injured brain or seizing brain, normal hemoglobin or normal oxygen saturation to start with, if there is no normal oxygen saturation, or the saturation is less than 85 or less than 80%, there is hypoxemia, then we need to deal with. And the normal blood flow carrying the hemoglobin or saturated hemoglobin to the end organ. So these are the 4 factors. And if you have a change in this number here on the near-infrared spectroscopy, it could be due to one of these factors. So when you look at the monitor now, let us talk more specific about what are the abnormal values on cerebral oxygen saturation. When you look at the monitor, you will see multiple numbers. You will see the big number here, which is the cerebral oxygen saturation, and you'll see a small number here with the yellow circle, which is the previous number. And there is a trend by percent. So the brain saturation was 42% for some time, and then suddenly increased to 81% from 42, which is the baseline. That's significant change in the trend. Anything more than 20% change in the trend is significant. So what I need in ICU to know, I need to know what's the baseline and change in the trend. And the change in the trend, not for 1 minute or 2 minutes, more than 30 minutes. That's our protocol in our unit on routine monitoring. So we are accepting low cerebral saturation beyond the postnatal transition, 60% up to 80%. There's a normal range. And the change in the trend more than 20% from the baseline is significant. For 1 minute, 2 minutes? No, for 30 minutes. So if you have 30 minutes, half an hour with the abnormal change in the trend, then I have to react. And how to react to that, I will discuss that in the next slide. So again, we have the 3 numbers we need to look at on the monitor. The current number, the previous trend, and the percent change in the trend. So simply, we are monitoring the oxygen delivery. And the oxygen delivery is the 3 things: the blood flow, hemoglobin, and oxygen saturation. So just assume that we have in this circle, black circle, we have the venous saturation, which is around 70 to 80% saturated, and the saturated RBCs represented in the red circles, and unsaturated is the blue circles. So we have around 80% saturated. From the right ventricle goes to the lung to be fully saturated, and now it is 100% in the left side of the heart, and then going from the left side of the heart to the end organ, fully saturated, 100% saturated, and the brain will consume the 20% or the 25%, and then goes back to the heart. So that's our normal oxygen delivery, just simplified in 4 steps. Simply, we are evaluating the cerebral oxygen saturation by near-infrared spectroscopy and arterial oxygen saturation by pulse oximetry. And then assume that we have low oxygen delivery, and how we have only 4 circles instead of 8 circles. So the capacity of the oxygen delivery decreased by 50%. And now we have the venous oxygen saturation is 50%, only 50%. And this could be due to low blood flow. So you have very low blood flow or low cardiac output, or it could be severe anemia. Both of them represented in this circle here. So we'll just go through the same process. So if you check the oxygen saturation, again, as mentioned by Dr. Yousfi, it's 100%. But the brain oxygen saturation detected the issue now, because now the brain trying to compensate by consuming more, consuming 50% of whatever delivered to the brain. And what about in hypoxemia? Hypoxemia, you have the blood flow or the cardiac output is normal, but you have less oxygenated hemoglobin. So you have here the normal blood flow and normal hemoglobin, but the number of red blood cells, blue desaturated, is almost half of the overall. So you have very low saturation. So the lung cannot saturate all of that, will saturate probably partial. So you have the arterial oxygen saturation now about 75%, which is typically, for example, in congenital cyanotic heart disease. Now the brain will try to compensate by consuming from the venous compartment. So in this situation, you will see the pulse oximetry 75 and the cerebral oxygen saturation around 50%. So let us talk about hypoxemia and autoregulation in a little bit more details about their physiology. Hypoxia or hypoxemia secondary to increased oxygen demand or decreased oxygen delivery. So the brain could be consuming more oxygen. For example, in convulsion, during convulsion, there's high oxygen demand, which might end up by brain injury if it is prolonged, or there is not enough oxygen delivery. In this situation, there is what's called hypoxic vasodilation. So the brain blood vessels will vasodilate, and that happened due to release of nitric oxide. So with the decreased hemoglobin or decreased oxygen saturation and hypoxemia, and again, just in this slide here, you have the three systems responsible for maintaining oxygen delivery: respiratory system, blood, or the blood content of hemoglobin, and the cardiovascular system as a blood flow. If any defect in any one of them, that might lead to low oxygen delivery. So the first mechanism to compensate is hypoxic vasodilation, which is release of nitric oxide, release of local nitric oxide from the endothelial cells and from RBCs. But there's a capacity of autoregulation. If autoregulation reaches the maximum and there is no more capacity to compensate, the next mechanism to compensate is increased oxygen extraction. So the brain will try to extract more from the leftover intravenous compartment to compensate for the decreased oxygen delivery. In number one, you will see the near-infrared spectroscopy normal, or even the trend is higher than normal. But once you see increased extraction, you will see the number decreasing less than normal. So in autoregulation, you will not detect any significant change. But once you see oxygen extraction, it is a red flag. Red flag, then the oxygen delivery is decreasing, and that's one step before anaerobic metabolism. Typically, if you don't have near-infrared spectroscopy and the infant with septic shock, directly we'll see lactic acid due to anaerobic in the blood gases, because you don't have the window, or the red flag can let you know about the ongoing issue in the end organ, which is too late to see lactic acid in the blood gas. Because the next step, once you have anaerobic metabolism, you have end organ dysfunction, which might partially recover. You may not have the end organ recovered completely. So how we investigated that? Again, as I mentioned before, we have two distinguished type of research. We have to use the randomized control trial when we have everyone is the same population and randomized very specific intervention. RDS gives surfactant or not gives surfactant, or caffeine for apnea prematurity or no caffeine or placebo. That's a very clear question. But when you have hypoxemia or change in the physiology, this does not work. You need to apply a lot of detailed physiologic studies, which can be animal-based studies or can be human-based studies. As you can see in the picture here, in our animal, state-of-the-art animal integrated hemodynamics lab, and we are using a piglet model in this lab, and we investigated the model of hypoxemia. So we induced lung injury in piglet model, and we have also control group, and we tested lung by lung ultrasound the degree of lung injury, and we tested by serial blood gases the hypoxemia, and the continuous monitoring of the brain, kidney, and abdomen by near-infrared spectroscopy, as you can see here. And we did echocardiography to assess the cardiac output and detailed hemodynamics as well, parallel to near-infrared spectroscopy. And you can see the team here, and this article is under review for publication, or this work is under review for publication. And as you can see, the lead of this project was Dr. Asli Memiş from Turkey, from Istanbul, and she joined us for 1 year as a research fellow. And what we found in this interesting study, in the brain near-infrared spectroscopy, we have the control group without lung injury and the hypoxemia group with lung injury. When you apply oxygen up to 50%, almost the same, but when we started to reduce the FiO2, you can see the brain's consuming more oxygen without development of lactic acidosis, up to around 30% change in the trend from the baseline. The gut was not as significant as the brain, probably because in hypoxemic infant, the brain trying to maybe survive longer, and probably the gut was not as active in metabolism as the same like brain. Kidney was also significantly different between injury and the control group, a lung injury and the control group. So this significant change in the oxygen consumption, signifying that the brain and hypoxemia trying to survive and trying to consume more oxygen even before you see lactic acid in the blood gases. And what we need from the monitor? We need to understand if the brain is consuming and still compensating well by consuming more oxygen before development of end-organ dysfunction. There is no lactic acid in any one of the piglets because we ended the study at a certain point. We did not wait until get end-organ damage. And in this study as well, I have to mention that all of the blood gases and all of the other parameters was consistent with the near-infrared spectroscopy results. So what are the indications in general? Also to just reflect whatever we are doing now in our unit in Winnipeg. And also we implemented the same protocol in another unit in Vancouver, the unit that Dr. Samer Youssef is working, Surrey Memorial Hospital. So we have 5 indications of near-infrared spectroscopy. HIE on cooling until rewarming to understand if the brain is consuming or not. If the brain is not consuming and continue not to be consuming during your rewarming, it means that the brain is almost dead or there is significant brain damage. And there is actually a recent meta-analysis signifying that use of near-infrared spectroscopy is predictive for poor outcome in HIE and cooling infant. Preterm infant less than 27 weeks during the first 72 hours of life until stable. It might extend to 5 days, 6 days if the infant is unstable, and that's our protocol in the unit. And we have specific interventions, what we need to do. Simply to check the blood gases, check hemoglobin and the blood pressure. Preterm was post-hemorrhagic hydrocephalus until stable. If the infant was hydrocephalus, the head ultrasound might let you know about the significance of hydrocephalus as anatomy, but does not add you too much about the blood flow, the compromised blood flow secondary to hydrocephalus. In case of severe hypoxemia, if the infant requiring oxygen more than 50% to guide weaning, so we may accept less than usual target saturation as long as the brain oxygen saturation is okay. And that's actually consistent with the animal study that I just showed you. When you accept lower target saturation, that's still okay for some time until the infant recovers, instead of just giving too much oxygen, which might induce more damage. Hemodynamic instability until stable. So any infant with shock, regardless what type of shock, the near-infrared spectroscopy can let you know about the magnitude of or impact of decreased blood flow in the end organ. So how to interpret abnormal cerebral oxygen saturation? So we have here the expected issues with increased cerebral oxygen saturation or low consumption, and the most common or frequent issues highlighted in red color. So increased oxygen delivery, you give too much oxygen, which is very common in NICU, brain injury as HIE, hypoglycemia because the brain requires oxygen to metabolize glucose. If there is no glucose, there is no consumption of oxygen. Polycythemia, if you have too much RBCs, probably you have too much oxygen as well, or oxygen delivery. Hypercarbia, if you have too much CO2. CO2 is a very strong brain vasodilator, or over sedation or anesthesia might also decrease brain oxygen consumption, which potentially might affect the cerebral or brain outcomes. What's the opposite? In decreased cerebral oxygen saturation, or when you have high consumption, sorry, it is not low consumption, it's high consumption. When you have hemodynamic instability, when you have hypoxemia or anemia or hypocarbia, low CO2, lung overinflation, or brain compression by hydrocephalus. The interventions listed here, they are at the bedside, and then all of our nurses and also a respiratory therapist and physician, they know what they need to do when they have low consumption or when you have abnormal levels. So they need to adjust FiO2, reduce the mean air pressure, or lung recruitment, or hemodynamic, check for hemodynamic instability, or check for the blood pressure or perfusion index, and so on. So in case of hypoxemia, let us focus on hypoxemia now. And I have this case scenario. It is very clear when you explain the value based on the experience from the unit, a real case scenario, which is kind of common case scenario: premature infant with hypoxemic respiratory failure due to chronic lung disease, almost 100% FiO2 for the last 2 weeks on mean air pressure of 16 with high frequency jet ventilation. So let us listen to the bedside nurse, or sorry, let us actually go over the two options now. Which option is safe and physiologic after appropriate lung recruitment? So you have the infant with oxygen saturation 90 to 95. If you are using oxygen saturation target 90 to 95, regardless of underlying physiology, or you can accept lower target saturation or wider target saturation 85 to 95%. So in this option here, you need 100% oxygen, you need higher ventilatory setting. In the other option, you may get like FiO2 less with less ventilatory setting, but the only difference here, the guidance from near-field spectroscopy. When you give too much oxygen here unnecessarily, you will get cerebral oxygen saturation very high. But when you allow the oxygen saturation to be a little bit lower, what you need to do just to be sure that the cerebral oxygen saturation is still within acceptable level, above 60% or 60 to 80%. And this is a way that we use the brain oxygen saturation together with the pulse oximetry to guide oxygen titration. And we published that in a very clear algorithm, published article in the Journal of Pediatric Pulmonology. And the concept is when you have severe lung disease, you have significant lung collapse, which might not recover quickly, and assume that you have 50% lung consolidation or collapse, and you have 50% shunt. So assume that you have one lung with normal ventilation or 50%, and you have the other lung with no ventilation, but you have perfusion. So the blood is going to the healthy part of the lung, 75%, and leaving 100%. But in the collapsed part of the lung, the blood is leaving 75% without a change. If you give 100% oxygen, will not change this ratio. So you have 87% overall saturation, which is average between 75 and 100. If you give 100% oxygen, that will not change. You give nitric oxide, will not change. So you are obligated, and you don't have any other option other than just accept lower target saturation, and also to be sure that the brain is still consuming normal oxygen to apply near-field spectroscopy. And this is what we are using in our unit. Titrate the oxygen based on both 60 to 80% cerebral oxygen saturation, and also a little bit lower target saturation in this severe chronic lung disease. I have another case scenario to highlight. It might be a big issue to accept low target saturation for infant with congenital heart disease. We have low birth weight infant, 1.8 kilogram with congenital cyanotic heart disease on mechanical ventilation, and the cardiologist recommended to maintain saturation more than 80% until time of surgery, which is like the infant should grow up to 2.5 kilogram. So to maintain saturation more than 80% or in more than 75%. To get 80%, the infant requires 100% oxygen, higher ventilatory setting. But if we accept 75% saturation, we are able to wean down to 35 FiO2, 35% with less ventilation setting. But the difference is the near-field spectroscopy is a little bit lower on this arm here, but still acceptable, 65% cerebral oxygen saturation. On the other hand, here you are exposing to this growing brain to too much oxygen to reach the target. So to pick up just a target randomly, that's that might be dangerous or might be harmful to the brain. You need to make the brain happy with acceptable oxygen, not too much oxygen and not too much less, as also described by Dr. Yousefi.
So this is a preterm infant born at 1.5 kilos. Cardiology would like us to be greater than 2 kilos before cardiac surgery. So far, our oxygen sats, as gets set by cardiology, is to be set at 75%. Right now, our cerebral oxygen sats are setting at 30%. Dr. Al-Said, what can we do?
Yeah, 30% for the cerebral oxygen saturation is really low for a premature infant with low birth weight. So the brain growth should be optimized with the better oxygen saturation. I would actually try to get the arterial oxygen saturation higher, maybe more than 80%, and see if that will improve the cerebral oxygen saturation. Hi, Marianne. What is the cerebral oxygen saturation now after we adjusted the arterial oxygen saturation to more than 80%?
Well, with our slight increase of oxygen on the monitor, we were able to increase our cerebral oxygenation to 50%, and our O2 sats then turned up to 80.
Okay, wonderful. I think we are safe now. We can continue the same until we get this baby fit for surgery after the weight increased to 2 kilograms.
Thank you, Dr. Al-Said.
Okay, I think now you can realize there's two different scenarios. The first scenario, when the cardiologist suggested the saturation to be higher than 80%, that was too much oxygen to the brain. In the second scenario, the recorded one, it was the opposite, totally exactly the opposite, when the different cardiologist suggested to get the saturation more than 75% is enough, but the cerebral oxygen saturation with 30% only, and we had to increase the acceptable target saturation to be more than 80% to get the brain saturation higher. So you may get totally two different scenarios in the same pathophysiologic mechanism of hypoxemia, congenital cyanotic heart disease. So he cannot assume just a random number to accept as arterial oxygen saturation without understanding how much your brain is consuming. That might be totally different from premature infant or from infant to another infant. And this is highlighting that you cannot randomize everyone. You cannot assume that everyone is the same to get one favorable outcome. In this algorithm here, you have hypoxemia due to right to left shunt. So oxygen, we apply oxygen reduction test by pulse oximetry and NIRS, and see the impact of that on the cerebral oxygen saturation. Identify the lower FiO2 to maintain both the arterial oxygen saturation and the cerebral oxygen saturation within the target. It could be cardiac right to left shunt. So until time of surgery, you may maintain cerebral oxygen saturation more than 75% or more than 80%, whatever, to maintain the cerebral oxygen saturation within the target. You have to make the brain happy. Not too much oxygen, not less oxygen. The same for the lung. If there's intrapulmonary shunt through the lung, so severe hypoxemia due to parenchymal lung disease, treat underlying cause, consider good sedation to avoid crying, which might increase the intrapulmonary right to left shunt. Cerebral oxygen saturation 60 to 80%, and you may accept wider target saturation 85 to 95%, or even narrower to 85 to 90%. Again, we published titration of inspired oxygen in premature infants with hypoxemic respiratory failure using near-infrared spectroscopy and pulse oximetry as a new approach. So you can read more about this approach. Just quickly to summarize the oxygen prescription based on both. In premature infant, first 72 hours of life, we accept the target saturation 88 to 92%, like midway between high and low target, as long as the cerebral oxygen saturation 55 to 85. During the first 72 hours of life, we accept a little bit wider range because the physiology during the first 72 hours is a little bit different. But the premature infant less than 32 weeks, during the era that we expect, or during the period that we expect development of ROP, maintain 88 to 92%, the same, and the cerebral oxygen saturation 60 to 80%. But growing premature infant with post-menstrual age beyond 32 weeks, Now the ROP is less likely, and now the corrected age beyond 32 weeks, but the pulmonary hypertension might be developing in this population with more frequent desaturations. Then you need to go up a little bit in the target, 90 to 95%. Again, the brain saturation 60 to 80%. With the significant VQ mismatch, was due to significant lung disease, 85 to 95, make it a little bit wider to avoid significant fluctuation, to avoid the bedside nurse playing too much with the oxygen knob, and the cerebral oxygen saturation 60 to 80%. In the right to left shunt, intrapulmonary right to left shunt, or cardiac right to left shunt, intrapulmonary right to left shunt, 85 to 90%, and the cerebral saturation is the same, 60 to 80%. Pulmonary hypertension, you need to maintain 90 to 95% arterial saturation, and the cerebral oxygen saturation 60 to 80%. In pulmonary congestion, for example, left-right PDA, it's better to accept lower target saturation to limit the shunt, to increase the pulmonary vascular resistance, 85 to 90%, as long as the cerebral oxygen saturation 60 to 80%. In cyanotic congenital heart disease, it's a little bit variable, more than 75%. Sometimes you may need it higher than 80%, and your target, you need to maintain 55 to 85%, and less than 50% is red flag for congenital cyanotic heart disease. I think, or hopefully, you will be able now to answer yourself the 4 questions. So we went over the first question, does near-infrared spectroscopy monitoring improve outcomes? We don't need this answer from research. What we need to answer, we need to be sure that the near-infrared spectroscopy give us a physiologic parameter that can lead to intervention, or physiologic intervention, or formulated medical recommendation. Number 2, how can NIRS be a vital sign? It is compensating for missing a piece of information, which is end organ saturation. And now we went through how to benefit from that. Number 3, what are the indications in general? 5 main indications. Infant with hypoxemia, premature infant during the first 72 hours of life until stable, infant with hemodynamic instability, infant with hydrocephalus, and HIE on cooling until rewarming. How can NIRS help in hypoxemia? You can use near-infrared spectroscopy together with pulse oximetry to titrate oxygen if the hypoxemia related to lung disease or also related to congenital cyanotic heart disease. Thank you very much, everyone. And happy to hear your questions and comments.
Thank you very much, Dr. Al-Said, for this great talk, putting things together, and how to use NIRS clinically. Just for the time's sake, we're going to go quickly to the Q&A session. And before that, I would like to introduce our panelists, Dr. Afifi and Dr. Faruqi. So Dr. Afifi, I know the introduction is late in the presentation, but she is associate professor at Dalhousie University and a neonatologist in Halifax, Canada. She has a great portfolio about patient safety, quality of care, neurodevelopment, and she is one of the experts in neurocritical care. And as this relates to this subject that we're discussing now, and she's involved in research with NIRS. Dr. Faruqi is a neonatologist in Manitoba, and he is also the leadership for the neurocritical care in their hospital. So moving to this session, I think we received a lot of questions during registrations, but most of those questions have been answered during the presentations. But there are a few interesting questions that actually most of us want to hear from the speakers and the panelists. The first thing to start with is to kind of emphasize that Dr. Gabriel Al-Tate left a comment about resources. Like a lot of people asked about protocols, NIRS protocols and resources, and he left a link to the Neocardio Lab, his website, him and his group, where he posts a lot of resources about protocols and how to use NIRS, how to apply NIRS. This will be very beneficial to everybody and it's free material to download, so please take advantage of that. And then a question that came a lot in the on the questions is how to start a NIRS protocol. So I will direct this question to Dr. Samer Yousefi. I can see him. Dr. Youssef is there. Yes. So since you just started, like you have a newly implemented the NIRS program in your hospital, maybe you can just give people some ideas about how it looked like to implement a program, some obstacles, some barriers or advantages, and what was easy, what was difficult.
Sorry, Nadia, before sorry to jump in. Yasser, could you please stop your sharing of your screen? Yeah, stop sharing. Down. Yes. Thank you. Okay. Yeah. Yes, Dr. Samer, please go ahead.
My interest in NIRS was during my training. Then it was all kind of in hibernation for almost 10 years until Dr. Al-Sayed joined us, and he revived all this interest, and we had a great discussion. So all the credit should go to Dr. Al-Sayed for bringing this innovative kind of technology at my side. With him joining us, and then also another physician joining us, were interested in neurocritical care. We approached the foundation, who agreed to fund buying the machines. And again, during this process, the concept explaining, and that's really important, and I keep emphasizing it, the importance of introducing the concept to staff, not just physicians, RT and nurses. They don't want to see a machine and just numbers they need to add to their sheet. Explaining the physiology behind it made them engaged. They were asking questions. They were asking how implementation, like if you see their faces and their interaction, I think that was a key for introducing near-infrared spectroscopy. We just started 2 months ago. More than 50% of the staff are trained, mainly the nurses who care for level 3 babies who benefit from. You're not going to have everyone benefiting from this monitoring. Certain group, and like what Dr. Sayed mentioned, we have very similar eligible kind of criteria. We explained the rationale. We started implementing it in a way it's not completely 100% nursing responsive. Physician has a responsibility of reviewing it frequently during the day as we're implementing it. Really, as of 2 weeks ago, pretty much I can say it's been successful. The way how we approached it, making sure nurses more buying it before physicians, making sure education well established before implementation. For the last 2 weeks, it's almost the routine. Everyone is aware who benefit. Everyone aware when I say it's low, the NIRS is low. Oh, the nurse will just say, oh, the consumption is high. Why? Let's troubleshoot it. So engage the staff. That's a key for successful, I think, introduction. But again, the credit should go to Dr. Al-Sayed. So you need the physicians who are interested. You need the nurses to buy it. You need a good education. You need the money to buy the machines. It will happen. It makes sense. It's like we're not making things up. Numbers, physiology will speak to itself. It's very interesting.
Thank you very much, Dr. Yousefi. Dr. Adel?
Adel, you are muted. You are muted.
Oh, we cannot hear. Okay, he can't hear. Okay, I will take it on and ask the next question. And the question is actually very interesting because I've always wondered about this one. It's from Dr. Sukaina Gabriel. And the question is, with the use of NIRS in patient with HIE, how do we know, like when the saturation is high, how do we know if it is the effect or the impact of hypothermia or because of the brain injury? Maybe Dr. Faruqi can comment on that. I think I see your reply there, but just maybe for a greater discussion.
Thank you, Nadia, and thank you, Dr. Sekanak. It's a very good question. During HIE, near-infrared spectroscopy shows high reading. So exactly this high NIRS reading is because of the hypoxic insult, or it is because of therapeutic hypothermia, because we know that therapeutic hypothermia also shut down the brain. So there is no oxygen utilization by the brain, so you will have high NIRS reading. And sometimes even those babies are high prone for seizure or abnormal movements, and there is very low threshold for people to give anti-seizure medication. And we know that anti-seizure medication also suppresses brain activity. So you might also get high NIRS reading. Even those will be also sedation. So exactly this high NIRS reading is because of the hypoxic insult, or because of therapeutic hypothermia, or because of anti-seizure medication. It is very difficult to mention. But as Yasser also mentioned, NIRS will help you in the integration of all this. NIRS is one of the number which help you in the integration. If baby is therapeutic hypothermia cooling, but you are getting NIRS reading of 60s and 70s, 60s or 70s, so it means that then less likely to be severe HIE. So that is the
Yeah, very good answer.
Can you hear me now?
Okay.
Can you hear me? Yeah. Just
Go
to
ahead,
follow up
Dr.
for
Sayed.
this question, Mansoor, one of the audience asked for same population, the HIE population. When you put the NIRS on, are you allowing to use lower limits, or you are still going with the same range, knowing that there is brain injury? Do you go by 60 to 80? Do you widen the range? Do you narrow the range? Accept a little bit lower, or it continue the same the range as any well baby that you will put the NIRS on?
So, yeah, that's one more very good question. Adel, exactly, I don't know the right answer, but we are using the same numbers. We are using for the HIE baby same 60 to 80s. Yeah.
Kind of feeling that this could be the right answer, because we should have normal range, and this should be applied to everyone to know which one is sick, which one is not sick. But yes, sir, if you would like to put some light on this question, would be great.
Yeah, thank you very much. It was a wonderful answer from Mansoor. I would like to highlight that near-infrared spectroscopy does not give you the complete answer. We are integrating NIRS to other parameters that we are using in monitoring neurocritical care related patients, including HIE. So we're using a continuous EEG monitor, and we're using also in between the head ultrasound with the cerebral anterior cerebral artery Doppler with the resistive index. So when we put everything all together, we make it a better idea if the abnormal number is related to seizure activity, which we'll see that on EEG, or related to the impact of cooling, or related to low blood flow. You may have HIE infant with LV dysfunction and low blood flow. Then you have to add echocardiography to the package. So it just give you a trend of number that can let you know there's a red flag and you need to maybe investigate more. Based on the number, should we use the same number or not? It is not more about the number, it's about the trend. Yeah, you need to follow the trend over time. If the infant from the beginning is 90% saturation, cerebral oxygen saturation, and does not change, you started rewarming, does not change, and there is no any other parameters like fluctuating, then it means that the brain damage is really significant. If you have 70 or 75 and then suddenly increase to 85% or 85, so that's a significant change in the trend, more than 30 minutes, you need to investigate. It's the same way as we do everything. You need to check the blood gases, the blood pressure. You may need to do head ultrasound with Doppler and check the EEG results. Is there any ongoing seizure, or you give too much sedation? So according to the checklist, you need just to consider which ones make more sense with the abnormal trend in the number, based also on other parameters change at the same time. One of the limitations that also we need to keep in mind for NIRS, it is reflecting only the cortex, because the depth of the laser of the NIRS is just 1.5 to 2 centimeters deep. So that does not really reflect the damage in the basal ganglia or deeper part of the brain. That's why we need to wait until we get the MRI. In MRI, you'll get more idea about the deeper structure of the brain, which might not be detected during the monitoring, routine monitoring. The same like EEG. EEG just detect the cerebral cortex electricity, does not really reflect the deeper structures. And we have seen that. We have seen normal number in NIRS, normal EEG, and when we did the MRI, it was severe thalamus or basal ganglia injury. That's why it's a package that we need to complete. So no one parameter can give you a clear answer for everything.
Thank you, Yasir. And just to add one more thing, if in case you are having high NIRS reading, still after therapeutic hypothermia, you finish therapeutic hypothermia and you are now maybe 4 or 5 days and still you are having high NIRS reading, then definitely there is a severe HI inside.
Thank you. And I think Dr. Youssefy has a question for Dr. Al-Sayed.
Thank you.
That's one question.
Yeah, I'm just, do we know a value, NIRS value at which most likely the tissue extraction is significantly compromised and will start making lactic acid? Do we have like, definitely I can say 40, that's too low and lactic acid is happening now, I should fix it, I'm not going to accept. The other question, we all know during fetal development, fetal PO2 in 30s, their SATs in 60s, they don't have lactic acid in utero. The fetus is growing in kind of relatively hypoxic environment. Why they don't make lactic acid in utero? I'm assuming because their extraction is not compromised. But to me, if I have a tool to measure NIRS for the fetus with the PO2 of 30, probably it's going to be 20. Do we have a physiologic explanation for both questions? Thank you.
As expected, very smart question. As expected, always from you. Regarding the cut limit, again, it's based on the trend. When you see the trend is going down, it's a red flag. So if you see the cerebral oxygen saturation is going down, as long as it's still down and there is no lactic acid, means that the extraction is still compensating. Once you see the numbers going back to normal, that's a more significant red flag. It means that now the tissue started to damage, and now the tissue cannot compensate or extract. So the extraction is a good sign, or relatively good sign. It means that the tissue is trying to compensate. But someone's typing on the computer.
Yes, please mute yourself, Gani.
Yeah. So when you have the number is low and the brain is extracting more, it's a good sign. Or relatively good sign. It means that there is no significant tissue hypoxia yet. But you don't have to wait a long time watching that. You need to react. But if you see the number is going back to normal, it could be two things. It could be back to normal because everything is improved, or it could be back to normal, which is very bad sign. When you have the blood pressure still low and the infant still really deteriorating and lactic acid started to appear. Once you see the lactic acid, there is no role of NIRS. Now you are outside the window. You will see the number normalized, even higher than normal sometimes, because now the tissue does not consume oxygen. Now the tissue is almost compromised and dying. So this is a sequence that we need to follow. It's different from tissue to tissue. Some tissues might compensate to 35. I have seen as low as 25% in the gut ischemia.
You mean 25% with lactic acid or with no lactic acid?
There is no lactic acid. There's no lactic acid yet. When you have lactic acid, the number actually will increase because it means that the tissue now is almost suffering and there is no capacity to extract oxygen. That's the first part. Let me answer also the second part about the fetus, which we don't know a lot of like the actual answer, but from the physiology, the fetus compensate for low saturation by high cardiac output. The cardiac output in the fetus is almost double because it's the both left and right ventricles, they are working for the systemic circulation because the lung is still not working. So it is double the number. So the high cardiac output is compensating for low saturation because at the end, the oxygen delivery is cardiac output, saturation, and hemoglobin. The other part is the fetal hemoglobin has very high affinity to oxygen, and the extraction is much less at the tissue level. I mean, very slow. And the third part, the fetus mainly focusing in growth. There is not too much activities other than just growing. So all of the oxygen delivery dedicated to growth, brain growth and the body growth. So that's the main aim of the oxygen delivery. There is no digestion, no lung function, no other sources that might consume a lot of calories and make the brain or the other organs working more than expected.
And Yasser, in relation to Samer's question, I put in the chat a link for, there are a couple of studies on fetal NIRS actually, and there is one particularly interesting one that they combine the NIRS with the fetal monitoring, the CTG, cardiotopography, to predict the fetal acidosis so that they can manage intervention for delivery, whether C-section or instrumental delivery or continue with the planning for that. I think I agree with many of the things said today, particularly that the NIRS is a vital sign, so we should use it as a vital sign and to give us some information about the physiology and information, then integrate this information to individualize patient care. So the asking the right question in the research, yes, it is about the intervention. So I think the research is only telling us about the guidelines that were used with the NIRS, not the NIRS itself. But I think there is lots of evidence that NIRS is associated with a brain injury, whether in preterm or term infant. It's associated with brain injury diagnosed on MRI and predictive of outcomes. Now, how we can integrate this information to target patients' care, it's more than having one recipe fits all. So, like Yasser and Samer and Gabrielle today provided lots of resources on how to use guidelines in how to integrate this information at the bedside. I think is very useful for centers that use it routinely or for centers like our center that use it for research purpose. I think understanding what it cannot offer and educating ourselves and our team around that would help to get the technology implemented.
Wonderful. Thank you very much, Jair. It's very good.
One more question, Yasser, came, unless Mansour, you can go ahead with the question.
Two questions from Dr. Ismail.
Mansour went. I can go ahead, this one. So one of the audience is asking about the evidence behind choosing that 60 or 60 to 80 is the acceptable range. I think there is some studies early on that looked at huge number and found that this is acceptable. But yes, if you can highlight some of the evidence behind using this range in our population. Hello?
Is it like the question to Mansour or to me?
directed to you, but Mansour highlighted the question.
Okay. Okay. Thank you very much. Yeah. It is a long story. It started actually with adult literature. So in adult, they selected 85 to as an upper limit to 55, based on the correlation with the mixed venous saturation in normal subjects. So that was a long time ago. So we are using near-infrared spectroscopy to reflect mixed venous saturation. And the mixed venous saturation in adult literature, they took the sample from the pulmonary artery catheter, which is used to be a modality to detect mixed venous saturation in adult intensive care units. So that was correlation between near-infrared spectroscopy and mixed venous saturation, true mixed venous saturation in this population. And then we inherited the same number in NICU or in other units or other age groups like pediatric, using the same value, based on probably even in neonatal or pediatric subject, you may have the same mixed venous saturation, although it is really difficult because we are not using the pulmonary artery catheter as a routine. Sometimes we are using umbilical venous catheter in the right atrium, which is not true mixed venous saturation. Simply because when you have beta infrared ovale or ASD, you have some of the arterial blood present in the right atrium, which will give you a false mixed venous saturation. You need to push the catheter into the pulmonary artery to get the real number. Over time, when we did more research, physiologic-based research, we realized that beyond the postnatal transition, using 60 to 80% make more sense. There is a very interesting study done during the first 72 hours of life to decide for the centile values. So there's centile values considering as low as 50% during the first day of life and increasing gradually in premature infant. We used this centile values to build a calculator which is available on NewBeats Academy. You need just to enter the number on NIRS, and they will give you the reference value based on the centile compared to the age and postnatal age in as a premature infant. Before that's before or during the first 72 hours. Beyond 72 hours, you can use simply 60 to 80% to any population to make it easy.
Thank you, Yasser.
Should we, I think for the time, should we wrap up?
Yes.
We don't have, yeah.
We need to wrap up because it's a prayer time for most of us. May I request Yasser to give a vote of thanks to all the speakers, panelists from the audience. Yasser, please.
Yeah, I would like to thank everyone, the participants, whoever I think I can see like a very big number as expected joined us today from all over the world. Although there is actually a challenging time because we have a lot of participants from the east side of the world, which is really late night time now for them. So thank you everyone for joining us and asking the smart questions. As always, we learn from your questions and we improve our knowledge based on your questions. I would like to also thank our wonderful speakers, Dr. Samer Yousfi and Dr. Gabriel Altit, for joining us today. We learned a lot from your presentations, and that was really great add to our knowledge. Our great panelist, Dr. Mansour Farouqi, my colleague here in Winnipeg, Dr. Jaheer Afifi, for your participation and participation in the discussion. It was really great add to our knowledge. Our great moderators that actually supporting us at any time we ask them to join us. And they are generously supporting NewBeats for so many years now, almost since we started. Dr. Adil Mohammed, my wonderful colleague, and also the other wonderful colleague from Ottawa, Dr. Nadia bin Fadel, and Dr. Muzaffar Ghani, who actually started very early in the morning to check all of the technical support to get this event on this wonderful platform successful. So thank you very much for organizing everything for the last couple of months. I would like to thank all of the support members from New Beats and Focus New for helping us to get this event successful, and Meditronic for generously supporting this event without any contribution to our scientific material, as expected always from them. I hope that I did not miss anything, but Muzaffar, you can just maybe like you can just add or whatever you would like to add to end the session. Thank you very much.
Thank you so much. Thank you, Yasser, and thank you everyone for this for making this session wonderful. Everybody has contributed, and we learned a lot every time. And just a few instructions. So this site is will be active. It is not just finishing today. And then we will be posting some information or materials in this site, so you can visit anytime. One, you can look at the materials posted. Second, the recording of this session will be posted in this site. So the same sign in this portal, like the same link what you've got, and you can visit again, and you can watch the sessions if you had technical difficulties. I know some of you had problems when you logged in your mobile devices. Unfortunately, the platform is not supporting the mobile devices, and you can watch those sessions if you want to, and that will be prepared in a couple of days, and it will be posted in the portal, and all the resources also will be ready. The handouts also already has been posted, and thank you for your continuous support, and we will be meeting shortly, like in 2 weeks, in Toronto for the upcoming major conference, international conference, the respiratory conference in Toronto, and see you all there on May 2nd. If you have not registered, please register as soon as possible to fill out that last few seats left. Thank you so much, and have a wonderful evening, every one of you. Thank you so much.
Thank you.
Thank you. Thank you, Jair, Mansour, Nadia, Adel, Samer. See you soon, everyone.
Thanks.
See you.